Hi, welcome to It's Like This podcast, your common sense mental and spiritual talk show. My name is Dr. Eugene Kim, a dual board certified psychiatrist from Texas. In this podcast, I explain mental and spiritual concepts with fun analogies, real stories, and positive message so you can not just survive, but thrive. My goal for you is to gain understanding, acceptance, and healing so that you can know your worth and live the life that you are meant to live. If you want that as much as I do, hit that subscribe button and let's listen to today's episode. In this episode, I'm working with Dr. Ted Williams. I met Dr. Williams during my training, and he became my mentor in psychiatry in so many ways, in private practice and incorporating faith with work. As I am, quote unquote, growing up as a baby attending psychiatrist, he was amazing at being vulnerable and encouraging at the same time. Dr. Ted Williams is the founder and board certified child, adolescent, and adult psychiatrist of Genesis Behavioral Health in San Antonio, Texas. He's an adjunct faculty at Department of Psychiatry and Long School of Medicine, UT Health Science San Antonio, and also at the University of Incarnate Word School of Osteopathic Medicine. In his previous career, he was a board certified in family medicine and practiced family and emergency medicine before later specializing in psychiatry. Guys, just know that residency is horrible and it sucks, so the fact that this man went back to residency is an amazing commitment. He's an educator, proponent, and an expert in TMS, a transmagnetic stimulation, a new technology used to promote the healing of the brain circuits involved in depression and other mental illnesses. In this episode, I'll be asking all the questions you wanted to ask about TMS. Does it hurt? How much does it cost? What are the side effects? And is it for me? I learned so much in this episode, and I'm excited that you will too. So let's get started. All right. Well, welcome to It's Like This podcast. I'm Dr. Eugene Kim, and we have a special guest today. And he is my first psychiatrist who is here as a guest. And a little bit about Dr. Ted Williams. I met him when I was training at UT Health San Antonio. And, we maintained this kind of friendship and mentorship, mentee relationship for a few years. So I'm so excited and honored to have Dr. Ted Williams. Welcome.
Thank you, Dr. Kim. It's an honor. And it's really wonderful to see your professional career grow and blossom and doing this podcast. You are putting out great information, and I am honored to be your guest.
Yeah, thank you so much. And, the reason why I reached out to Dr. Ted Williams is he's kind of like a local expert in this therapeutic device called TMS. Can you just explain to us what TMS is?
Yeah, TMS stands for transcranial magnetic stimulation. And so if you break the word down, transcranial, or it's magnetic stimulation, like as opposed to electrical stimulation or some other kind. And transcranial means through the skull. So a magnetic coil is put outside the coil, and the magnetic energy just flows right through skin and skull as if it's not even there, reaching the brain on the other side. And it's been shown that multiple pulses, like 3,000 or 4,000 pulses in a single treatment, activates a network in the brain.
So that's a lot of words, but just for our listeners, I didn't. So psychiatry treatments are evolving. I think a few decades ago, only treatment option that we had was like ECT, and which we'll have another episode, and medications. But now there's so many exciting treatment options, and TMS is usually for treatment-resistant depression. That's kind of how it started. But, it's evolving. So I'm going to ask Dr. Williams, what is it? And what, how can we use it? who is it for, and all that information. So, Dr. Williams, let me get to know a little bit about you. You're a psychiatrist, but I know that it wasn't your first career path. So can you tell me, like, how did psychiatry kind of fall into your life?
Yes, actually, I wanted to be a doctor since I was a kid. My father was a family physician, and that's all I ever wanted to be. I went to medical school with full intention of becoming a family doctor, which is exactly what I did. I did a family practice residency in my hometown and opened up a family practice an emergency medicine practice right there in Corpus Christi, Texas. And I did that for uh, all total with training and practice about 10 years. Um, and then tragedy struck. My father died. And there were other things going on in my life that really caused me to pause and reflect what did I love the most about medicine? I love all of medicine, but what do I love the most? And what I love the most is helping people who are hurting.
Mm.
It's kind of funny, psychiatric issues. Some doctors will turn and run away from it. I turn and run towards. I don't know. I don't know why. It just is. And
Yeah.
so yes, so I went back. We moved from Corpus Christi to Houston and spent the next 4.5 years doing my psychiatry residency and child and adolescent fellowship and with absolutely no regrets. I love psychiatry and love what I do.
Yeah. And that is very similar to mine. Like when I was attracted to psych patients, that's when I knew that it was a calling because not a lot of people can handle or understand psych patients. So I was just like, this must be a calling.
Yes, yes.
So do you think, with the background of family medicine and some emergency medicine, from your practice, do you think that kind of makes you have different approach in psychiatry?
It probably does. For for one thing, medical issues don't scare me.
Mm-hmm.
I'm familiar with them. I sometimes um, might be listening differently to the patient's history and symptoms. Like gosh, I'll never forget a woman who came for a consultation about getting TMS,
Mm-hmm.
and during the consultation, she talked about some symptoms that in my mind did not add up as pure psychiatric symptoms, and I began to wonder about a brain tumor.
Oh,
Um,
wow.
and lo and behold, that's exactly what she had. Uh,
Wow.
and so that sort of thing is really rare. But psychiatrists are first and foremost physicians,
Mm-hmm.
and I just had a little extra time doing general medical practice and getting that experience. And yeah, I think it did. And the other thing I think it did is I think it made me more open to the idea of doing TMS.
Yeah.
Because in psychiatry, we're generally trained to prescribe medications, have relationships with patients, do psychotherapy. And so the idea of doing an intervention to someone
Mm-hmm. Mm-hmm.
can be a little daunting, a little scary. Um, but but if you're trained to do a spinal tap, um, that's a lot scarier
Yeah. Yeah, I remember.
than putting a harmless magnetic coil on a person's head
Yeah.
and treating with TMS. So I think probably it has made me more interventional in my thinking.
Mm-hmm.
Uh, and lastly, probably it has made me more holistic in my
Mm.
thinking because the science has just been pouring in over the last 15 years about the role of um, uh, nutrition, inflammation,
Mm-hmm.
sleep,
Mm-hmm.
exercise, social connectedness, mindfulness, and prayer. All these things have a really important impact on mental health and the healing of mental health conditions.
Yeah. And TMS is relatively new because I just graduated a few years ago, and I don't think we had a like official rotation in TMS, even a few years ago. So it's been here for quite a while, right? You said that it was like around 2012
Well,
when
actually,
you
it was
got the machine.
yes, 2012. Actually, TMS was FDA approved in 2008.
Hmm. Mm-hmm.
Um, like it's not new anymore.
Yeah, it's
It
not.
didn't get to San Antonio until 2012 when I got a TMS machine and another clinic did, and we collaborated some uh, in those early years, and so but the problem with TMS is really still very few people even know about it. And physicians and psychiatrists know about it, but they are not familiar enough with it to know sort of when to recommend it.
Mm,
Um,
mm-hmm.
and and so I think still there's this tendency that, for instance, with depression, once a medication has failed, to try real hard, the psychiatrist to try real hard to think about what next medication is most likely to be effective. Um, but then after a while, there's this law of diminishing returns. We're
Mm-hmm.
trying more and more medications is just simply not going to be effective,
Right.
or the chances of it being effective are much reduced.
So let's talk about that because most of our listeners, I think, tune in because I try to explain mental health in a very easy to understand language. So some people might be like not even aware that they have mental health issues or concerns, and they listen to this and they're like, oh, maybe I do. So some come from medication very naive, you know, or even mental health concept naive. And some people maybe had multiple medication trial, like you're saying. So we have like a pretty diverse, awareness. And you just mentioned first try the medications a few times, get help if you think you need help with medications. But for those who are discouraged, by multiple trials of medication, you're saying that somewhere in between that, TMS can be a solution.
Absolutely can. Now, insurances will. So, by the way, all major insurances cover TMS.
Mm-hmm.
Which most people don't even know that. So,
Yeah.
cost is not the barrier that it was 6 or 7 years ago. Um, and insurances will cover it when most insurances will cover it when patients have tried at least two medications,
Mm-hmm.
and they may have worked, but they didn't work well enough to completely relieve depression. Two medications and uh, at least some sessions of talk therapy, psychotherapy, counseling.
Mm-hmm.
Um, after failing two medications, the chances of the third medication completely resolving depression is only about 15%. The fourth medication, it's only a 7% chance that that medication is going to completely resolve depression. So that's why I say there's sort of a law of diminishing returns. And I've had patients, that have been on like 15 tried 15 different
Mm-hmm.
medications,
Mm-hmm.
all in hopes of finding that silver bullet, that will completely relieve the depression. But I think what we know now is that for some people, the networks of their brain are not working sufficiently well for a medication even to work.
So two things. What do you mean by failed trial? Because some people will take a week and they're like, I have loose stool. I don't want to take it. Right. Like,
Oh,
so they
okay.
only tried it for a week. So can you explain to me what failed trial of one medication is?
Yes. So a failed trial means one of two things. Either the medication didn't work well enough, or it caused side effects that the patient can't or doesn't want to live with.
Mm-hmm.
So a failure can be due to medication not working, but it could be due to side effects.
Mm-hmm. Mm-hmm.
And medications frequently cause side effects. I mean, I think the most common side effects that are big turnoff are weight gain,
Mm-hmm.
sexual side effects, feeling emotionally numb from the medicine. People will say, "Oh, doctor, yeah, I feel less depressed, but sometimes I wonder if I feel anything."
Mm-hmm.
I was at a funeral the other day, and I couldn't even cry. So
Mm-hmm.
so so a side effect that's not tolerable is considered a failure.
And is there like a time duration?
To a minimum of 2 weeks. Uh, in the first 2 weeks, an antidepressant medication, majority of time, will declare itself
Mm-hmm.
as to whether or not it's going to work.
Yeah.
Uh, there are a few there are some instances in which the onset of effectiveness of the medication is later, 4 weeks, 6 weeks, 8 weeks. But by 8 weeks, by a 2-month trial of medication, if the patient is not what we call in remission,
Mm-hmm.
um, okay, we borrow that term from cancer. So if in cancer, if it's in remission, the patient might have microscopic cancer, but the cancer is not detectable in that patient.
Mm-hmm.
So with depression, remission is that, well, there may be, a few little symptoms of depression left, but really depression is not detectable compared to a non-depressed person
Mm-hmm.
on a
Mm-hmm.
rating scale. So I would say 2 months of medication not completely resolving the depression is a failure of that medication.
Right, right. And so just for the listeners, like just 1 week of trial and mild side effect, I don't want to take it. That would not be a full course that Dr. Williams is talking about. Is despite your effort to try it, it's not working, for X amount of time, or severe symptom that is like hindering you from continuing to take the medication, that'll be considered failure. So um just to kind of recap, because we had this talk, most, not most, but good chunk of people might respond to first trial medication, but then there's a portion of people who don't. And then they try the second medication, and there's some portion of people who get better, but there's big chunk that don't. So now we're talking about, let's say, third group of patient, after they failed 2 trials, they're possibly I guess, target population for TMS. Is that right?
Yes. Um, Failure of two medications, or maybe a third, and having therapy, and we can come back to why therapy is so important.
Mm-hmm.
Uh, but if those trials of medication either haven't been effective or have caused side effects, um, rather than trying more and more medications,
Mm-hmm.
uh, TMS is statistically there's a lot higher chance of the depression resolving with TMS than with trying another medication. And
Mm-hmm.
the sad truth is that after trying two medications, about half the patients still, their depression is not resolved.
Mm-hmm. Mm-hmm.
It, no, even after trying, 3, 4, 5, 6 medications, there's still 1/3 of patients that do not reach remission on medication. That's
Yeah.
a lot of patients.
Yeah. And you mentioned brain network. I want to talk about, I'm not like sciencey as much as in regards to brain. And you mentioned network, and I'm thinking that that could be the explanation why multiple trials of medication might not work for these people, and why TMS might be a solution for them. So can you explain to us like the network deficiencies that you kind of um, talked about, touch on that, and why TMS could be a solution for that?
Sure. Well, so, over my career, the brain has gone from being sort of a black box. We
Mm-hmm.
had no idea what was going on inside, um, to now there's an understanding that the brain operates as a series of networks, anywhere from 7 networks to 17, depending on how you count. And what is a network? A network is multiple areas of the brain, each with a specific task connected to one another in order to carry out a brain function.
Mm-hmm.
So it's multiple areas connected together to carry out the brain's functions. That's a network. And and so the brain is highly electrical. People don't really realize that. It's bioelectrical. There's um, chemicals that uh, help create the electric charge. But the brain communicates with itself through the little wires of the brain that operate in a network. I still remember uh, in the 1990s when functional MRIs came out. So a functional MRI is not just the structure, brain structure. It has the ability to show how the different parts of the brain are connected to each other, working together.
Mm-hmm. Mm-hmm.
And so they brought us into an auditorium, sat us down, uh, threw up a summation of 7 patients who had been instructed to think sad thoughts, and they had their MRI scan while they were thinking sad thoughts. And in all the patients, the same area lit up.
Mm-hmm. Mm-hmm.
And I just thought, oh my goodness. Uh, so we've always known that the brain is the organ of the mind,
Mm-hmm.
but not how.
Right.
And so we're finally beginning to barely get a peek as to how the brain is the organ of the mind.
Yeah. So, and it's always changing. I love the unknown territory of psychiatry research because sometimes
Yes.
we have these, conceptual, very simplistic answers like serotonin deficiency, like we talked about, before, and then it's like gets debunked. So, you know, I know that we're just scratching the surface, but and also I think before they were like, oh, this area is emotion, and like, but it's not as
Yes.
simple. You're
Yes.
saying like these are just groups, like one factory can be part of multiple networks. And we won't get too nerdy and explain all the networks, but basically there's a function of networks. And for the people who try multiple medications, and let's say we're talking about specific to depression, and they're not really getting better, which network is kind of needing that kind of stimulation?
Well, the primary network that we're targeting with TMS is called the Cognitive Control Network, or Salience Network is sort of the official name. And this has to do with the ability to switch thoughts, and in particular, uh, not think about things that either are unhelpful or harmful.
Mm.
Um, and we do it unconsciously. Negative thought comes in, and a non-depressed person will just, or something they can't do anything about. Non-depressed person will just push it out of their minds.
Mm-hmm.
Not someone with depression. Um, that thought, someone with depression will think literally hundreds of negative thoughts in a single day.
Mm.
Yeah. So uh, so decreasing the the impact of those negative thoughts, to be able to switch them off, that blow off things that need to be blown off,
Mm.
uh, is rather than always seeing the glass as half empty, seeing everything as black or white, seeing things all or nothing.
Right.
Dis Something positive happens, discounting it as not being relevant. Something
Right.
negative happens, totally focusing on it as if it's everything.
Right. Right. Yeah. So this salience network, and so something, if a person has like significant depression, there's salience network is dysfunctional to the point that medication and therapy cannot improve. So how does, you mentioned transmagnetic stimulation, and you also mentioned that brain is like an electrical biochemical, network. So how does that kind of come together? Like how does TMS machine like stimulate the salience network?
Yes, it is fascinating, from a scientific perspective,
Mm-hmm.
um, that as a law of physics, energy forms energy can take various forms. Magnetic energy is easily translatable into electrical energy, and vice
Mm-hmm.
versa.
Mm-hmm.
So think about the hydroelectric dams in Tennessee. Really, these are giant magnetic rotors that the water flows through and turns, uh, and that's what creates the electricity and powers the Tennessee Valley.
Mm.
So, so, uh, so that's going from magnetic to electricity. So, in the case of TMS, the magnetic coil is put on the scalp. A pulse is given. The brain is just sitting waiting on the other side. It receives that magnetic energy and converts it into a tiny little current of electrical energy. So the brain cells themselves convert the magnetic energy into electrical energy at just the right power.
And does that, so when it converts it to electrical energy, does it grow or shrink, or
Oh
how
yeah,
does
yeah.
that change the
Or
brain?
yeah. So it excites an area of the brain, a little over an inch in diameter, a little over an inch or inch and a half deep. It excites those nerve cells right under the magnetic coil. Those nerve cells and every other area of the brain that's connected to that area in a network all
Mm-hmm.
gets all gets all get charged up. And so you could think of TMS as taking a brain network to physical therapy. It gets its
Yeah.
workout. And what does this workout do? Well, if the network has gone weak, it likely means that there are not enough connections in that network. And so stimulating the network grows connections. I don't think it's been proven yet, but there's scientific evidence to infer that literally certain areas of the brain would grow after 7 weeks, a 7-week course of TMS.
Yeah.
And why? Because the infrastructure of the brain itself is being rebuilt.
So just to kind of recap, TMS is a magnetic stimulation, brain converts it to electrical energy, and certain targeted spots of a network would be targeted and stimulated, and eventually it will kind of grow and become more functional over time. Is that a
Yes,
good,
yes,
accurate description?
that's a great description of it.
Perfect. And but I'm just kind of being a devil's advocate, or participant in the audience, and be like, well, then it just kind of sounds like I don't need to take medications every day. That's a hassle. I don't want to do therapy. That's too vulnerable. Now I just want to zap my brain, so that I won't be depressed. And to kind of argue against that, you do something amazing in your clinic, is that it's not just TMS, and you want to bring the power of therapy. So can you explain to me like how that protocol has initiated in your clinic?
Yes. So we've been doing a TMS since 2012. And we know from many, many research studies done over decades from various centers around the world, we know approximately how effective TMS is. A third of patients receiving TMS will reach remission under the controlled conditions of a science experiment. In real life or in practice, actually the odds are usually better than that. I would say for many clinics, the remission rate is maybe in the 40s, 45, 40%.
Mm-hmm.
Well, pretty early on, it became clear to the scientists around the world that combining psychotherapy with TMS was going to produce a better outcome than just simply receiving TMS alone, like something being done to you and that's it, is not as effective as both receiving the treatment and being engaged in a therapeutic setting. So we really took this to heart. Everybody thinks it's a great idea to combine therapy with TMS, but it's not so easy to pull off. So we built a team of therapists so that instead of a medical technician being the one that after I decide the treatment location on that first visit, how everything is supposed to be set up, after that, I'm not in the room during the treatment. A technician is of some kind, someone who puts the coil in the right place and presses the right buttons and so forth. And that function is often served by a trained medical assistant. Well, we decided to make the treaters people who are licensed therapists or therapy students, so that the patient is receiving therapy while they're getting TMS, which results in quite a bit of therapy because a course of TMS is about 30 or 45 minutes a day, 5 days a week for 7 weeks. And we have them sort of as captive audience all that time. What about having a therapist there in the room, or as their team, as a part of their team, with one goal in mind, and that is helping them get out of depression. Here's the thing about treatment-resistant depression. If a patient has been depressed long enough to be getting TMS, for them, depression is not just the way they feel. It's become a way of life. They have let activities go. They've let relationships go.
Yeah.
And why? Because frankly, there's just not the energy. Hopes and dreams completely put on hold. So recovering from an extended period of depression is not just a matter of feeling better. Yes, feeling better is required, but it's also a matter of re-engaging with life to be the person that you would be if you weren't depressed. And so we think, well, who better than a therapist to link arms with you and help pull you out of this quicksand that you've been in? Who better than a therapist? And so we have a team of therapists, and generally the patient will have 2 or 3 therapists that they get to know on different days during those 36 treatments. And so we had one of our patients refer to them as they're my homies. They're my team.
Yeah.
And these are the people who are helping me envision a different future, the walls have gradually closed in on me during depression, and I need to break through those walls in order to become me again.
Yeah.
That's the role of a therapist, and that's why it's been so powerful. And since we have done begin using a therapy team with our TMS patients, our results have gone through the roof.
Mm.
Through the roof. I want to tell a quick little scientific story that's illustrative of this.
Mm-hmm.
There was an experiment, back in the 1970s, of a fish, a walleyed pike. And this is a northern fish, aggressive. Anglers love to catch these fish because they fight so hard. Well, they put in a large aquarium a walleyed pike and some minnows. And in short order, the minnows were gone. They were food for the walleyed pike.
Yeah.
Then they slipped a thick pane of glass in the middle of the aquarium, and the pike was on one side and the minnows were on the other. So the pike, then darts for the minnows, runs right into the pane of glass, thinks whatever a walleyed pike thinks when they're
Like,
just bump
whoa.
their head, whoa. And then the second time, go again, but not with quite the same vigor that they would the first time. And then the third and fourth, and less and less and less. And after a while, the walleyed pike gives up. We call this learned helplessness. Learned helplessness. Why? Because when you then pull the pane of glass out, the minnows will be swimming around the walleyed pike. The walleyed pike won't go after them. It has learned those minnows are off. They're out of my reach. I don't know why they're out of my reach. They're out of my reach.
Yeah.
Learned helplessness. There's an extremely strong correlation with human beings and depression and learned helplessness. Because if you've banged your head up against the wall 100 times trying to beat back depression, but nothing is working, then there's a sort of a settling into a new normal that excludes the person you really would be if you weren't depressed.
I definitely heard that from my patient because she was on partial remission from depression. And she asked me, should I just accept this for the rest of my life?
Right.
And she wanted me to say yes, because then now she can move on. Like, okay, you're telling me I can expect this for the rest of my life. So it was even almost painful to hope.
Yes. Yes.
And that is so sad.
Oh, it is. It is. Yes. And so, being able to envision a future without depression is really helpful. That's hope in action. Is envisioning what life would be like without depression and beginning to act on that. That in itself has a healing effect.
Yeah. And it's almost like, if you fail multiple trials or medications, multiple trials of therapy, there's even, instead of opposite of placebo, there's nocebo effect where you're like, well, let's see if this one works, and there's that hopeless indifference, to the treatment. And I like that you're incorporating not only innovative treatment, interventional treatment, but also a team that gives you some social support and a community, it feels like, to really help the patient to have like a completely different approach.
Yes, right. Yeah, and we also there is a weekly support group of all the patients who are currently receiving TMS. It's an education and support group of each week we tackle a different topic of things that we believe are helpful in fighting depression. And so they get sort of a sense of community with the therapist team. They get a sense of community with some of the other patients. And so, yeah, I think and they derive hope from that.
Yeah.
And because they are feeling better with the depression treatment of then they're actually able to act on it, and then engaging in life positively brings more positive engagement, which brings more positive engagement, and so
Mm,
things are finally headed in the right direction.
yeah. And you mentioned like when you're getting TMS and you get a therapist kind of talking to you and talking with the therapist. I'm imagining I never got TMS myself, so I don't know, but does it hurt? Like is there pain that would distract from talking, or how painful is that? Or not painful at all?
It's not painful. We are not allowed to use that word in our clinic.
It's a taboo.
It's not painful, and we have a lot of control over how it feels given the power level that's being used. Most patients describe it as annoying, so it is annoying. You feel
Okay.
it. We finally call it the electronic woodpecker. It feels like something's tapping you on the head. Um,
Uh-huh.
and so it is annoying, but it's pretty easy to ignore and talk with the therapist during the treatment. And
Okay.
some people have gotten so used to it that a few patients want to sleep during the
Oh,
treatment, which we do not allow because the brain state changes when one is asleep. Um,
that's right. Hmm.
so TMS is tolerable enough to interact with the therapist,
Yeah, or sleep, or possibly sleep.
possibly sleep.
So you mentioned it's not that painful, or it's not that
Uncomfortable.
unbearable. Yeah, I
Hmm.
cannot use the word painful. It's every day for 30 to 45 minutes for about 7 weeks. So that's kind of like one course of
5 days a
TMS,
week. 5 days a
5 days
week.
a week. Okay. And you mentioned that now you're incorporating psychiatry, or sorry, psychotherapy, but can people be on medications when they're doing TMS too, or is it like one
Great
way or the
question. Great question. So most of our patients stay on their antidepressant medications. If they're on a medication that either has a lot of side effects or maybe is not one of the more safe medications, we encourage considering discontinuing those. But being on some sort of antidepressant medication is more common than not being on one. Um, there are a few people who they're just done with medication.
other?
They have given it many tries, had many side effects, and they are not on medication. TMS works for them as well.
Mm-hmm. Mm-hmm. Um, so just to kind of recap, TMS, it seems like, because we have wide array of people who are medication naive and who has failed multiple medications. TMS is such a great tool, because I think some people come with me and they're medication naive and they're like, oh, what if this medication doesn't work? What if another one doesn't work? And I always remind them, I have other medication options, but it seems like TMS is a great tool in the toolbox. Even if medication fails, is a very effective tool to treat, treatment or medication resistant depression.
It really is. So this year we've had our best year ever in terms of treatment outcomes.
Mm-hmm.
Um, so this year, the first 6 months of this year, our remission rate was a whopping 64%.
Wow. Wow.
So if you compare that fourth medication trial remission rate of 7%
Mm-hmm.
versus 33% or 50% or 64%. I mean, the odds of TMS working are so much higher than more and more medications that it's time to switch gears.
Right. And just to put into perspective of percentages, what Dr. Williams is saying is in remission is like if you're in a fourth trial of medication, maybe 1 out of 10 people might feel better and the 9 won't. But you're saying with TMS, 6 out of 10 people will feel better and 4 won't. So that's 1 to 10 for 6 to 10 ratio, and that's huge.
Yeah,
That's
right.
5 more people having hope in their life with 5 less people having hope in their life.
Yeah, right.
That's amazing.
Yeah.
Now I'm sure everybody, like I am, is very excited about this new tool, and depending on clinic setting, maybe I'll incorporate TMS into my own practice. But now, before everybody signs up for TMS, is there any contraindication, like reasons why you cannot get TMS?
Yes, the primary reason for not being able to get TMS is having metal inside the head. You say, metal inside the head? How could that happen? Well, it hardly ever does happen.
Yeah.
But it's possible that someone could have some magnetic type of metal from some sort of injury or whatever. Nowadays, even neurosurgery clips from neurosurgery they're usually made of titanium, which is not magnetic. But having something magnetic inside the head. Now, I'm not talking about dental or neck or anything. I'm talking about inside the head.
Yeah.
That is or cochlear implants.
Mm-hmm.
They are affected by the magnetic pulses. Those are contraindications.
Yeah.
Having epilepsy is a relative contraindication in that insurance companies will not cover TMS if a patient has a seizure disorder.
So can a pregnant patient get TMS?
Absolutely, they can. Now, it is not FDA approved,
Mm-hmm.
but there have been multiple research studies on pregnant patients. I have treated pregnant patients,
Mm-hmm.
and we don't have the level of scientific evidence that the FDA would require in order to give an indication for that.
Mm-hmm.
But
Mm-hmm.
but the physics of it is that the baby is so far away from the coil that the magnetic energy that they're experiencing is only at the level of the Earth's gravitational pull,
Right, right.
the Earth's magnetic energy. So and plus, as opposed to a medication, an antidepressant medication that a pregnant woman would take, then it goes
Mm-hmm.
around, goes through her whole
Mm-hmm.
body, including the
Yep.
baby, just to try to help the brain.
It's
Um,
so local.
the TMS is only affecting that area of the brain
Right.
or that network of the brain. So in theory, and maybe someday it will be the treatment of choice
Mm.
for depression
Yeah.
and even postpartum depression.
And so traditionally, pregnant women and children and adolescent are the hardest group to study for medications or treatment because they're so fragile, right? So can children or adolescent get TMS, and can you update us on the research on that?
Yes, so there's not an FDA indication for treating people under age 18. We came really close scientifically. There were a couple of large studies, one large study in particular that I'm thinking of that studied TMS for depression in teenagers down to age 13.
Mm-hmm.
And as expected, teenagers' depression improved with TMS. However, this was a controlled study. Some patients got real TMS. Some patients got fake TMS. It was double blind. Neither the patient or the researcher knew who was getting what. That's how we do our research studies.
Mm-hmm.
The problem is that the group that got fake TMS also improved. They improved so much that statistically, there was not what's called a statistical significance that TMS outperformed fake TMS.
Right.
And if you stop to think about it, it's not too surprising. This teenager is getting now daily attention
Yeah.
which I'm not saying teenage depression is due to not having enough attention,
Right.
but what I am saying is that the attention that they receive daily helps their depression.
Yes. Yes.
We have plenty of evidence that TMS is safe in teenager. We don't have definitive evidence that it works in teenagers.
Right. So it's like that research is not proving or disproving that TMS, or I guess I'm doing it a double negative. It's not proving that TMS doesn't work, but I think it always is interesting with children and adolescent studies, because it's like little attention they get so much better. And it's just like they can always use more love. They can always use more attention. And they're so delicate and sensitive. And it just kind of makes me smile because, having two little ones, it's just like they can always use more love. So I think that's a research to prove that. So, Dr. Williams, I am so excited about TMS. Like we talk about TMS all the time, every time we talk, and just more and more data is coming out, and you're using such an innovative and holistic approach, even with very innovative treatment tool. So that's very exciting. Do you have any like take home message for our listeners, who might be dealing with depression or even treatment resistant depression? Do you have any message for them?
I do. And for psychiatrists as well. For so many years, it was just me and my prescription pad. Old school. It's all electronic, but it's me and my prescription pad. If the first medication didn't work, then I would just racking my brain to find out what the next one was that I needed to try, because the patient was suffering. I would look under every rock if needed be to help them come out of the depression. What I didn't appreciate is the sort of the law of diminishing returns. And now we know approximately where to place TMS, and that is, after the second or third, certainly by the fourth antidepressant medication, it's time to try something else. And I think for psychiatrists who know about TMS, but they're not super familiar with it, they're probably going to be racking their brain trying to think of what the next medication should be, rather than stepping back and saying, we need a new strategy. And actually, I probably get far more referrals from TMS from the patients themselves who discover it online, or heard about it from a friend, or maybe their therapist, or maybe their therapist, than psychiatrists. Now, certainly psychiatrists do refer for TMS. I'm not bashing them at all, but I am saying that there needs to be a change of mindset from trying more and more medications to switching strategies earlier in the process. That's what I would say.
Yeah. So it's like medication is not a bad treatment option. It's not all or nothing. Therapy is not a bad option, but at certain point, we kind of have to have a, step out of that and then be like, is there something else? And now there's, safety, efficiency, and effectiveness proven with TMS. So let's bring the TMS into the toolbox for all psychiatrists to treat patients who are suffering and the patients who needs to stop suffering.
Yes, absolutely.
That's awesome. And, we briefly talked about this, but I love when we went through the depression talk that when, if anybody's listening, if depression kind of became the way of life for you, and you're kind of suffering by yourself and your hopelessness, I think I wanted the listeners to know that there is hope, and there's now going to be more and more tools in the psychiatrist toolbox. You're not alone, and there's great psychiatrists like Dr. Williams who's, giving 110% to, make these innovative interventions possible. So I really appreciate your time here, Dr. Williams. And if anyone's listening, I know you're located in San Antonio, but how can people find you and get to know you and maybe sign up for TMS or just talk to you about their options?
Well, our website is genesisbehavioralhealth.org. Is probably the best way to get in touch with us, and we have a lot of information about TMS on our website, so that can be helpful.
Yeah.
Or give us a call.
Yeah. And I'll definitely put all that in the description box so that you can reach out to Dr. Williams. Dr. Williams, thank you so much for your time. I think every time we talk, I learn something new about TMS, and it's so good to have, a passionate psychiatrist that was my mentor, but now we're colleagues. So I'm very excited about our collaborations.
Thank you, Dr. Kim, and thank you so much for having me.
So in summary, it's like this. I just want you guys to know that there's no point of sense of defeat when depression or mental illness is taking over your life. I think at each point there's new innovative technology, treatment options coming up, and don't give up, and please reach out to help. Again, you're not alone. This is not too late. And it's always a good time to ask for help. So I hope that was encouraging, and I really hope that you guys have a great day, and I'll see you in the next episode.